Namaskar. Thanks for giving me the opportunity to talk on anesthesia techniques for beard and mustache. The types of anesthesia we use is the local or topical application or general anesthesia like ketamine or nitrous oxide inhalation called as Entonox, sedatives or anxiolytic like midazolam and the diazepam. The Entonox anesthesia is basically 50-50% concentration of nitrous oxide and oxygen. Nitrous oxide is the strongest analgesic drug which has got safety, and during this anesthesia the patient remains conscious. This has been used for long, mainly for the obstetric practice, minor surgical procedure and for the children. Once you start inhalation, within 30 seconds the effects comes and it remains for the 60 seconds. So for the infiltration and for the nerve block, to reduce that pain or to create analgesia for that, nitrous oxide or Entonox anesthesia is good and safe, and one can practice for this. The topical application I use in all my beard and the chest cases, I keep it for 1 hour and 15 minutes. Then types of local anesthesia is the nerve block, the nerve trunk at the site of the foramen it is given. This reduces the total amount of the drug, but it is not reliable always because of the anatomical variation of the nerve. And to locate nerve precisely, we can certainly take help of nerve locator, which will precisely locate the nerve, and then you can give. The ring block, it is given at the periphery of the operating area. Then infiltration is given in the little lower dose than the nerve block dose in the entire operating area. And the Tumescence anesthesia, we all know, is a very diluted solution of local anesthetic with epinephrine. The purpose of using this is hemostasis and uniform prolonged anesthesia, and this reduces total amount of drug use to be used. Drug what we use during local is the lidocaine, bupivacaine and ropivacaine. I use ropivacaine and lidocaine mainly. I do not use bupivacaine because ropivacaine is mainly the sensory, and also it has got less cardiotoxic side effect. Vasoconstrictive is the epinephrine. Anxiolytic and sedative I use is the midazolam instead of diazepam. Midazolam short acting and no respiratory depression, and it has got amnesia effect, and many times the patient forget that he was given some injection. Then toxicity of the local anesthetic drug is, it is the dose dependent. If you exceed the safer dose, then there can be cardiovascular toxicity in the form of bradycardia, hypotension, CNS toxicity, which may start with perioral numbness, metallic taste, headache, confusion, and then the convulsion, and if not treated in time, then it may lead to death even. And to prevent this, I have made 2 check systems. One, this whiteboard I kept in my operating room, and we write the total dose what we have been used. Another thing is the safe amount of safe dose. Supposingly 1 vial I need for 1 patient, on that day in that OT only 1 vial will be kept. If I have consumed all and I ask to the staff that give me more, then they will tell me, sir, I will have to get it from the store, shall we? Then that's the sign or indication for me that I already consumed the safer dose. Now for the upper lip, the innervation is the infraorbital nerve, branches given here, which enters through the nasolabial fold region. This is just below the LA nasi, they enter. So when we give infiltration or tumescence to the upper limb, which is a common practice, it is very painful, very painful. So it is good to use nerve block at the nasolabial region in upper half region to block these branches of the infraorbital nerve supplying to the upper limb, and then you can give either infiltration or tumescence block, which certainly will reduce its pain and the fear of the patient. Then this can be given through external approach, means the transcutaneous, or it can be given internal, means the intraoral route. I give transcutaneous, means external approach. Then the lower lip, we all know, is the mental nerve which supplies the innervation to the lower lip, and the location of mental nerve foramen is in the line of mid-papillary line. And it's a good point that you should note that supraorbital foramen, mid-papillary point, infraorbital foramen, angle of mouth, and the mental nerve all lies in one plane, all are in one line. And to locate this mental nerve for you, easy is one line connecting to the mid-papillary point to angle of mouth. Then you take a point lower border of the mandible, angle of mandible, and midpoint of it is the foramen, which is the mental nerve foramen, and in 0.5 to 1 centimeter medial to this you can infiltrate to block the mental nerve. Then again it can be intraoral route you can give, and you can give outside, means transcutaneous. I give always externally. The neck, the nerve supply of the neck region is mainly by the superficial cervical plexus. The branches all are here, means the greater auricular, transverse cervical, and lower is the supraclavicular, now all three branches. And this is the area supplied by lesser occipital, greater auricular nerve, transverse cervical, and the supraclavicular. These are the nerves supplying. So almost the entire nerve, neck region is supplied by your transverse cervical nerve, and some lower part is by the supraclavicular. And these all are the branches of superficial cervical plexus. And the location of it comes from the posterior border of the sternocleidomastoid, means sternocleidomastoid, and the fascia. In between it comes out. So the midpoint is the mastoid, transverse process of C7, and midpoint to this, a line joining this, is the from where the superficial cervical plexus branches are coming out. So if you give local anesthesia in middle one third of the region of this line joining the mastoid to transverse process of C7, then you can certainly block all the branches of this, and you can anesthetize this area, or you can use the nerve locator precisely to block this area, which will further reduce the pain and the dose. And then you can give the infiltration and tumescence anesthesia. This will drastically reduce your pain of infiltration, fear of infiltration, and tumescence pain. As I said, to locate these nerves, you can use nerve locator or ultrasonic transducer. If not, then the best thing is you use the middle one third portion and infiltrate in this area. You have blocked all the nerves, and then infiltration and tumescence anesthesia you can give. This is the nerve locator which can be used. We all know these are the area for the beard extraction, and the nerve supply to this area is upper, means the cheek portion is from the branches from the infraorbital nerve and the mental nerve, and these are coming from the facial nerve, which are the motor nerve. These are the area. The option nerve block will certainly, as I said, reduce the total dose and the pain of infiltration and or tumescence. So you can give nerve block or ring block for the entire area, or you can give nerve block and tumescence. If you are using nerve locator or you are sure about it, and if you are given effective nerve block, then tumescence is enough. Means nerve block and tumescence is good enough for this. Or you can give a ring block and infiltration anesthesia. But remember, tumescence should always be given with any of the above anesthesia process. The options of extraction is, initially the conservative extraction is the submental region or inframandibular region, means the shadow area and the front of the neck we use. For that you just do the nerve block and the ring block or tumescence anesthesia or infiltration anesthesia, which I explained you before. Or otherwise, if it is extended, means you are planning to extract from even the chin and from the cheek and this area, then you have to extend your anesthesia region, which can be a ring block or infiltration nerve block, or you can give other nerve blocks. Then the position for anesthesia is also very important, that if you are giving a good position to the patient which is comfortable to him and to you as well, this will allow the patient to accept the anesthesia process more comfortably, and for you also it will be more comfortable. I have designed various positions. What you need is you open up the cervico-mental angle, so you get the space and properly you can inject in that area. One is this, another is this way, or third way is this. The most comfortable position is this, in which you can use the OT table, just proper position and do neck slight extension. In this you can do the extraction, and even the implantation, simultaneous implantation of the beard hair follicle is also possible, and anesthesia is also possible for every region. And patient tolerates, those patients especially who has got pain in the neck or other problem, it's a very good comfortable position, and especially for those who have got the short neck, for them this is a very good position. Now the anesthesia for the neck, I said I use the Prilox, then after giving the mental nerve block I give, and then to reduce the pain I use the vibrator. This is a very good quality of vibrator, ice pack, thinnest bore needle, inject slowly, and I always use the IV Mizolam for that. And Tumescence anesthesia, I tell you, is more effective than the ring block. Either nerve block or Tumescence, or ring block or Tumescence. That's how you can do. And Tumescence, if you give and wait for proper time, it serves almost all the purpose. And this is the technique how we do it. The shaving on operation table itself. Keep 2 mm of length of the hair. Then we define the area. I apply the Prilox in this region. Good amount means liberal amount of Prilox should be used, and it should be kept for enough time, and I keep it more than an hour mostly, and I realize then it really works. This reduces the pain of injection, means superficial pain is reduced by using this Prilox, and patients allows more friendly your injection, and the acceptability is also better. And during this period, patient also mentally prepare himself for the injection. I also use Mizolam 1 milligram. Ice pack is also used before giving the injections, before the infiltration or the nerve block. Then after giving the mental nerve block, the ring block we give, and then we give the Tumescence anesthesia. This is simultaneous extraction we do, myself and Dr. Anil Garg. We both surgeons does the extraction at the same time, and nowadays we are doing the implantation also, even from the beard, as I explained you in this position, which is comfortable. Now take home message is, the extra scalp beard is and neck region is a good source of extra scalp donor hair follicle, and we should practice to minimize the pain of infiltration of anesthesia, take care of the total quantity of anesthetic medicine, use good quality of vibrator, also you can use the nerve locator, and Entonox anesthesia is a good way of reducing the fear and the pain, and take care of the side effects or the drug interaction caused by non-selective beta blocker and anti-epileptic drug. Thank you very much.